Somebody say something, please.
Hey, Jeff, how are you?
Hey, Jeff, Michael.
There you go. Yeah, at the moment I'm frustrated, but other than that, I'm fine.
Good,
If
good.
you
Well,
leave
you,
your name, number, and a short message, I'll return your call as soon as I can. Thank you.
Odd start. My question is, when do we get to start meeting in person?
Not soon enough.
Could possibly be in September. We'll have to play that one by ear.
That's great.
Yeah.
Sooner the better.
Yeah.
Yeah. Make sure nothing else is open that's bothering me. Oh. Okay, well, I will call to order the Innovation Work Group. First agenda item is the approval of the last minutes.
This is JJ, I move to approve.
Thank you. Is there a second?
Second.
Okay, all in favor?
Aye.
Aye. Motion carries. Second thing up is the draft work plan. So Margaret, I think this is your ballpark.
yeah, certainly I will take it away. So attachment 2 in your packets is just sort of a high level overview, touch base of where we are this year. Which has been quite a year, certainly, for a lot of reasons. So looking back over the first half of the year, this work plan just summarizes the topics that the work group has already covered or has worked on, including things that are still in process, a couple of different topics that we have that will linger into fall. As you can see, we just kind of for June briefly list the note the topics that are on the agenda for today, the COE program update. That work is moving along, so we'll hear just an update on the status of that. We're also going to be talking about the next steps related to the Lodestar RFI, and then just another brief update on the status of our performance guarantee strategy and negotiation for upcoming contracts. And then looking ahead over the next 2 months, the work group has a planned hiatus for July and August. So we won't be meeting again until September. And to just in terms of an overview for fall, there are a couple of big topics on the horizon. We'll be looking at taking a look back at the hospital payment cap. In particular, looking at year 1 audit results, and that relates to the financial impact of the cap. Consultants will be working on that over the summer and expect to have results to present in September. Also to be explored over the summer are some more sort of delivery system impact analyses. So that's additional work that consultants are going to be looking into separate from the financial impact of the cap. This is more around, did we notice changes in the behavior of the delivery system after implementation of the cap? This is going to be an interesting area because, of course, essentially right after the cap went into effect, COVID hit, and there are a lot of things that impacted the delivery system over the past, say, year and a half. So I think, a lot of the work over the summer is really going to be around scoping and doing some data exploration to sort of see what analyses or information might be relevant to bring forward. So I would consider that to be a developing area, but somewhere I think where we can look forward to a further update in September. We'll also touch back on the Lodestar, and that the specific focus is kind of pending some of the discussion today. So that will, whatever comes out of today's meeting will of course be built into the work plan. And then September, I anticipate we'll have another brief update on where performance guarantees ended up. That'll be right before the start of the OEBB contract year, so everything will certainly be final by that point, but we will close the loop with the work group so that you know how that ended. Another big topic on the calendar for fall is value-based payments. It's really time for us to come and focus some attention back on that work, including both, I anticipate we will be making a request to carriers this summer for them to provide some updates in the fall on the status and their strategy around VBP. As noted, a lot has changed with care delivery in the past year plus, and we haven't really had the carriers give the work group kind of more an in-depth update on their strategy around that in a while. So that is planned for mid-fall. Working within OHA and OHA Analytics, it is likely, or I anticipate we will hopefully have some data on VBP levels to share in mid-fall. That is, still sort of being fleshed out, but it's quite likely we'll have something to bring to the group. And it'll also, I think, be time for the work group to, in light of all that, kind of re-examine the targets that the work group established back in 2019 and the glide path for PEBB and OEBB in achieving those targets. Also listed, and this is on the work plan for every month in the fall, a COE program development update. At some point in the fall, likely later, more like December, end of year, we anticipate we will be coming to the work group with some recommendations and asking the work group to, kind of formulate some more specific recommendations to the boards around pursuit of a COE program. And then looking ahead in November, we have some, I think it'll be likely we'll have some updates from the cost growth target program and how that work is progressing, which I think also will feed into the continued discussion around VBP status and strategy. And that kind of carries us through the end of the year at this point. As noted, I think, whatever decisions or direction comes out of today's meeting will certainly be folded into the work group. I think the goal was really to structure this as sort of high-level focus areas while still leaving some room for some flexibility as the IW strategy evolves. So are there any questions about that?
I don't see any. Okay. Thank you.
Thank you.
Looking on this small screen here for hands. Okay. All right. Next thing up is the progress on the Centers of Excellence project. I think Jenny's in Hawaii. So is it Brad or is it Ms. Flores?
That will be me, sir, Miss Flores. Taylor Flores here, joining you while Jenny's in Hawaii. I'm very excited to provide an update on kind of the work where we're at today with the Center of Excellence development. We've made a lot of progress over the last 2.5 years or so, and continuing on with that. If you want to move on to the next slide, great. Move forward, one more there. Thank you. So as I mentioned, and I'm sure as you are all very aware, there's been a lot of work in the innovation work group to determine cost drivers in the OEBB and PEBB population. And most recently at the April OEBB and PEBB board meetings, we presented kind of a business case for continuing this work and continuing this exploration and received blessings from both boards to kind of continue that work. So back on May 19th, we held the official kickoff of this project, which included members from the innovation work group, including Margaret, and carriers from both OEBB and PEBB's medical plans, as well as both Mercer and Willis Towers Watson consultants. That was a very productive meeting. It was very challenging to coordinate that many people's schedules. So a special shout out to Margaret for doing that. Thank you. But at that meeting, we really discussed what were the goals of this program, tried to outline, excuse me, kind of roles and responsibilities for the different folks involved in the project, created a project timeline that we'll use as kind of our guide path moving forward. And then also one of the bigger things that came out of that meeting were an initial listing of initial recommendations around volume and quality for developing the Center of Excellence program. As I'm sure a lot of you will remember, we did a Center of Excellence RFI, or request for information, to understand how some of the vendors that specialize in this area really make their programs work. So we learned a lot from that. We're learning a lot from our carriers, and really trying to work together here to create a great program for both OEBB and PEBB members. Dr. Siltebo.
I came to the IWG late. I'd love to see what other procedures were looked at. The ones that jump out besides the good thing about the orthopedic and neurosurgery cases are that they're elective and planned, so you can actually do something about it. There's cardiac cases that I could imagine that would be ones that were at least looked at, and there was another group of surgeries that I was thinking of, probably some vascular surgeries that are, if not elective, they're planned out, and you could actually direct people as compared to an emergency surgery. But I'd love to get a list of the procedures that were looked at before. Thank you.
Yes, absolutely. We'll take that as a follow-up. Thank you. Perfect. So if we want to move on to the next slide. So what we wanted to do today was to kind of give you a little bit of an eye into that May 19th meeting and what happened there, and then also help you with an eye forward and what we're looking at moving forward. So at that May 19th meeting, we really wanted to set the stage of reminding everyone why we were there. And it was really to focus on developing a center of excellence specifically for musculoskeletal procedures. We threw out some initial, not necessarily throughout, we analyzed data and are aiming for initially kind of that top 90th percentile or top 10% of providers, potentially looking at, aggressive reimbursement rates, such as 150% of Medicare, working those into bundles and warranties, which we learned are some of the best practices from those Center of Excellence vendors. And really, again, reminding carriers and participants in the call what the goal of the program is, but also understanding that we don't have all the answers, and there's not going to be a prescriptive, this is the right way to do it. So you'll see there on the right side of the screen that comments and questions were things that we wanted to discuss, were initial thoughts and reactions that our team had, or that we had maybe heard from carriers or staff. And again, just really set the stage that this is meant to be a collaborative dialogue between carriers and consultants and staff, and not so prescriptive.
So question, not that I'm opposed to 150%, we started out at 200% of Medicare on hospital. How did we choose 150% as a target?
So that was something that was prevalent in the Center of Excellence RFI responses as as a potential starting point for that, and then obviously realizing that as we get further into the contracting portion of this project, if we get to that portion of the project, there may need to be more discussion around that target.
So as we consider wanting to have a Center of Excellence program that's not Portland centric, so that we can allow for some other areas of the state, at least some from a regional standpoint. Just don't want that to be a barrier. Was there any discussion of a step approach?
Yes, absolutely. I completely hear what you're saying, and I would say that your thoughts are also echoed in the meetings that we've had, that we want to be sure that we're not from the get-go eliminating, potential facilities or providers that could be viable options or that could serve populations that are outside of the Portland metro area. So while we are kind of targeting an initial list and some initial metrics to get somewhere to start, we've had conversations and understand that those targets may need to move. And for right now, these are kind of guardrails while we're figuring out those initial pieces.
Sean, as the PEB representative or a PEB representative, what concerns does your board have about having access outside of Portland?
Yeah, I mean, it's a continuing balancing act. I mean, I know that I think we've been trying to communicate that this is likely going to be more restricted access.
Sure.
So I think where that conversation usually goes is to the transportation reimbursement and accommodations compensation for travel. So, but yeah, I mean, it's going to be a continuing debate. I mean, having said that, you know, I'm also attuned to, you know, not wanting to be, I don't know how to put this. I'm trying to think of a way to put this that's, I want to have a good price and don't want to be put over the barrel because I feel like I have to have a certain region represented, if that makes sense. So it's really just a balance. It's like 150% does not alarm me. That feels like a good target from my point of view. 150 or less, because part of the point of this is to have a high quality, lower cost facility that's able to have the volume to do this effectively, efficiently, and safely. And that may cause, you know, the travel dilemma, you know.
Yeah.
So it's you know, I want to be open to the discussion and to what the field has to say about it, but that's the tension that I feel is having good results for a fair price, while, you know, just that Oregon dilemma of, you know, there are some areas in the state where they're the only game in town, and so they're like, take it or leave it, you know. So that's kind of what we're trying to get away from here.
Jeff?
Well, I don't know whether the group as a whole shares my view, but I would love to see a side benefit of our program raising the level throughout the state, not just in one area.
Jeff,
Anyway.
this is Tom. Just the additional comment around, and again, I'm the latecomer to the group. When you looked at the large variation in cost, was it because people had a wide charge for basic procedures, or was it that there was a much tighter number around the basic procedure, but you were then paying for complications? Because the 150 is percent of Medicare. If it obviously that's driving on the cost side, but if you also aren't getting, you know, you're still having complications that you're paying for, you might be paying 150% of the complications, which is what's driving the costs up significantly. So what's most important with a Center of Excellence is the fact that you have high quality and that's associated with low complications, and you're not having to pay for that complication rate, which oftentimes can be 2 or 3 times the cost of the original procedure. So you know, it's the costs oftentimes follow a higher quality, lower complication rate, and then whether or not it's 150 or 200% of Medicare, that's not where the savings are. The savings are the fact that you're decreasing the outlier costs.
That Thanks for bringing that up, Tom. That is a fair point. You don't want to get overly fixated on the actual threshold number, because the other part of this that we expect to have savings is that a center of excellence would not hesitate, by our scheme, would not hesitate to dissuade a person from getting a procedure that is not appropriate for them. And that's the other part. And that would be difficult to capture in that 150% exact formula, right? Because that's something different. And I think what we're trying to arrange here is some kind of compensation system that is fair and also does not incentivize, borderline or dangerous, you know what I mean, approaching inappropriate procedures because they feel like they have to have volume or whatever. So anyway,
Yeah.
Well,
thanks for
I
bringing that.
apologize to the consultant for having started this rabbit trail to some degree, but we'll let you go 2 more pages because the subject will reemerge in 2 more, so we can continue then.
Hey, Jeff and Sean, this is Michael. I just want to make a comment that actually, if you go to Walmart and the Washington State Healthcare Authority, the largest savings that they claim is screened out people who were not appropriate for the procedure. About 25 to 35%, sort of to what Sean was saying. Yeah. So again, Sean, I just want to emphasize what you were saying, which is the screening out process, so that decision support is there, like the shared decision making, to know that there's treatment options available other than surgery is actually where the bulk of the savings comes from.
Yeah.
So in both Walmart and the Washington State Healthcare Authority, they've been doing this for several years now.
Yeah, and this is Louis. I was just going to add, this is actually a tiered approach where the cost piece actually comes in toward the end once we've already ensured that the volume, the quality, to the earlier point about things around treatment decision support are there, and looking at what sort of access is available. Obviously, cost is important and it's placed there. We recognize that there might have to be some flexibility. Where we don't want to have flexibility, however, is around the quality piece and drive and make that front and center. So comments noted, and we've had part of that conversation. In fact, that was raised on our call in June from some of the carriers about the reimbursement and is that set in stone or not. And we assured that it's a target, but we'll have conversations if it needs to be adjusted.
Yeah, I also want to just reiterate that, this is something that we're looking at in this group, but we have to pitch it to the full board, and then the board is accountable to our constituents. And if the message we give to our constituents is our primary focus is on quality of care, which in turn reduces the cost, that's a much more palatable message than, well, we're making you go to Portland because it's cheaper.
Right, absolutely. And I think on top of that, I appreciate everybody's comments here, because I do think at the core of all of this, it is about the member, right? We want to, well, as you said, JJ, we want to provide them a better quality experience. We would like for that to be at a reduced cost for both them and the plans if possible. And, to the points that were made earlier, provide that member support, that decision support, not only supports that member, but, also has other advantages to the plan as well. So completely agree, echo the focus on members, and that, obviously translates as well down to the travel benefit incentive. And we are definitely trying to make the member the focus here as we are thinking through a lot of these items. Okay. So appreciate everybody's engagement and commentary here. All right, we can move on to the next slide if there's no other comments for now. So again, at that May 19th meeting, we met a lot of folks from the carrier partners, from IWG staff and consultants, and wanted to kind of set the stage for what expectations were around responsibilities. And really, we're going to be leaning on the carriers to identify those initial lists of facilities and providers. We're going to be leaning on them to handle those negotiations of the bundles and the contracts. We'll be looking to them monitor the performance over time and really provide that member support and decision therapy, attempting conservative therapies first, and that portion of the program. Consultants and IWG staff will really help kind of keep the guardrails on the project. We are going to be making sure that metrics and reimbursements are aligned between OEB and PEBB carriers. We'll be there validating the information that is brought forth, the provider lists and the facilities that carriers are proposing including in this program. We know health equity has been a very important topic, both from OHA and for both boards. So we'll be ensuring that as we're thinking through consequences, both intended and unintended, that we're keeping a lens with an eye towards health equity on this project. And then obviously we'll need to make sure that we keep you all in the loop and keep the OEB and PEBB boards in the loop. And they, moving on to the right side of the slide there, OEB and PEBB will ultimately be responsible for either approving the recommendations that we bring forth for the program and the incentive design, or making recommendations or helping us decide where we might be able to make tweaks to make it a better program for all. So if we go ahead and move forward there.
Yeah, excuse me for just a minute. So whoever's running this, I've gotten in on my computer, but I'm waiting to be let in. So is that Margaret or Rose?
I think either of them.
Looks
like you're already in. But...
Yeah, I was going to say, Rose, I'm not seeing anyone in the waiting room. I don't know if you are.
No, I'm not either.
Okay.
I think it's because he's already in on one device.
All right. I'll close on my iPad. And
okay.
Second here for Jeff to join. So while we're waiting for Jeff to join back, I will just say that, again, we had that May 19th meeting with the carriers. We went through several slides that we've kind of condensed into this one here. But carriers we're really happy to see that carriers were very engaged in the conversations. We provided them with kind of worksheets to come up with a documented formal process for them to respond to our feedback. And over this next week or so, we are meeting individually with the carriers to discuss their responses and their thoughts and their comments behind each one of these metrics that we looked at. Jeff, were you able to join back?
While we wait for Jeff, when I looked at this, I looked at around provider volume, and one of the things that we'll need to build in is how to deal with new staff to a facility that is a center of excellence. So, it looks like it's a double process. The facility would be viewed as a center of excellence, and then the provider volume has to be such that they have, they get on the list as such. And how to deal with new people, if you only have people who are at a certain volume, they eventually retire, and then you don't have it, obviously new people are brought in. So a process by which people will be authorized will need to be included in this work. Now, obviously, that's the role of the carriers are going to have to figure that out because they're the ones with the direct relationship. But that's something that, when I looked at this list, something needed to be done about that. And it may involve just, people who have fellowship training within a certain area would automatically be included, and within X amount of time, they'd have to reach some volume level to be continued. But that issue needs to be addressed.
Exactly. Right.
Yeah,
Completely.
but I think also to consider, just because OEB and PEB are doing a center of excellence does not remove the total volume that these surgeons would have. So they'll still be accumulating volume, even if it's not necessarily OEB and PEB. So there still is an opportunity for them to accumulate volume toward the quality metrics.
I get it. I agree. But again, I would like the idea of being able to figure out how to bring on new people is something that needs to be worked out.
Taylor,
yeah. And I know we're tight on time, but normally with this, there's like a resetting or reevaluating process at either an annual or every 2-year process, and that would need to be built into it. I think that would hopefully address your concern that because somebody actually might get worse, hopefully not, but potentially could lose quality. So it's not necessarily a one and done from the beginning. It would need to have a process to reevaluate at certain intervals along the way.
Absolutely.
I was just gonna suggest, you'd mentioned Washington State and Walmart earlier. Are there other states that we can leverage, some of the best practices, so we don't have to learn our own lessons?
Yeah, absolutely. That's a great point, Ali. We have done that to an extent, and I think we'll continue to work at it from that lens of let's learn from others. We have leveraged data from carriers' national center of excellence plans to see how they've come up with these metrics and means of developing these programs and measuring their providers. So we've used that as a way to inform kind of the way we've structured this. We've also used data from the BRE Collaborative, which is a Washington State kind of a agency well known for their center of excellence development, and I've actually had the opportunity to meet with some of their staff there. So yeah, great suggestion, and definitely something that we are looking to leverage as much as possible with people that have, or organizations that have gone through this before.
Okay, I apologize for the interruption, but on my main computer, it just has me in the waiting room, and I'm feeling rejected.
I'm sorry.
No problem. Keep going. I won't interrupt us again on that.
No worries. That actually was a great segue, Ali, into this slide here, because really what our team worked ahead of that May 19th meeting was learning from those other carriers, learning from those other plans, learning from the BRE Collaborative to come up with, here's what we're thinking for some initial metrics. And again, you'll kind of see at the top there, volume. We're thinking at first there needs to be kind of a baseline volume at the facility level. Then once we've established that for these procedures that we're looking at, the providers at these facilities also need to have a certain level of experience and a number of surgeries, basic volume level, to really qualify so that we can then start to look at their quality. That quality piece will be a pretty intensive process, as there's a lot that we're looking into that. So it makes sense to kind of eliminate those who don't meet the volume requirements at first. Quality requirements we're looking at involve accreditation, patient, proving that they're focused on patient improved outcomes, complication rates, readmission rates. And then once that's been established at a facility level, and we are also giving special consideration and thought around ambulatory surgery centers, as we understand that, those are going to have different ways to look at some of those metrics. And then so once those quality metrics are kind of established at the facility level, then we'll start looking at quality at the individual provider level in an effort to come up with what we kind of call a short list, so we can figure out where those qualified providers are relative to OEB and PEB members. Any questions before we move on there? Okay, so this is a very high level. You may have seen this before timeline. As I mentioned, we have the project kickoff on May 19th. We're currently in the quality criteria kind of phase of the project. We'll hope to get to contracting in the fall, and then working through winter and early spring 22 to look at what an incentive design might look like. And then from there, implementation, planning, member education before a ideal go live date of October 1st, 2022 for OEB and January 1, 23 for PEBB. And then of course, measuring results for the year after and beyond to make sure, and as Dr. Siltebo mentioned, to continually monitor that quality and, potentially new entrants or people that may need to leave the program. If we move forward to the next slide, it gets into a little bit more of a detailed timeline here. And as I mentioned, we held that May 19th meeting. Right now, we're in process of meeting with the carriers individually to really discuss and hear their feedback on those comments around the metrics. I do very much appreciate that all of our carriers bring their clinicians with them because they provide a very unique perspective and a great perspective that we need, in preparing to have these conversations with these facilities and providers. I mentioned we'll come up with our short list. The carriers will come up with their short list of providers based on those metrics. And then in July, in August, we'll look for a geo access report relative to the OEB and PEBB population so we can really understand where does the access and quality kind of balance. From there, we'll look to update the IWG staff on where those providers are, what we're looking at for progress, and present to the boards to determine if it is appropriate to move forward on this project or if we maybe need to revisit some of those metrics we've established. If we move on to the next slide, we kind of move into the fall time frame. Again, that's when the carriers will be doing a lot of their contracting work with the providers, and consultants and staff will be working to kind of develop those recommendations around bundles for the procedures and warranties on those, and look to come to the IWG meeting in November and December with updates around those bundles and warranties and some recommendations around an initial travel benefit based on the geo access results of the provider lists. And then, as I mentioned, we'll look to hopefully go live at the end of 2022 and the beginning of 2023 and look to measure results and continuously evaluate the program. Any questions on that?
I think so. Don't see any hands. Okay. Thank you for that report. Next up, we have Lodestar. Mercer.
Okay. Hi, it's James. We have a short to medium deck today to sort of do a little refresher on what we learned and some ideas for shift in focus a little bit. So I'll start up and then hand it to Cindy. Next slide, please. Next slide again. So we had already presented the initial results of the Lodestar RFI. Another month has gone by and we have continued to mull those over and think about how they should impact our thinking going forward. To summarize, and I'll probably go a little bit quickly, but just jump in if I should slow down. To summarize, the advocacy space is pretty well developed, and our model was different but close to a lot of advocacy models. There are advocacy-only vendors. There are carriers who are embracing advocacy. So that was just sort of reassuring. We were still striving, I think, for a higher standard and a single point of contact that really solved members' needs. but the indicators were pretty favorable. On social determinant of health and integration with behavioral health, that's an acknowledged need, sort of industry-wide, but it's still in process, and I think there's far to go. We were quite well satisfied that some of the payment vendors, the network vendors, could administer our plan design for the Lodestar health plan that we specified. There were a couple of vendors that said, yes, we can help you with the direct contracts you're envisioning with the Medicare linking and the global budget. But there was a feeling that that idea would be challenging, and something we've been saying before the RFI, and they helped us to say it again after the RFI. There is good work being done in the quality and metric space, and we had some specialty vendors who are very strong in that area. So I think that was probably reaffirming. And again, the health equity priorities are acknowledged, but people are really still figuring that out. So there's not a solution there, and I think there's a lot of interest in participating in making one. Next slide, please. This is just a little recap of what we thought we heard from you all at that. We had some. Uh-oh, there's feedback. Someone might need to mute, unless it's me. Oh, good. We had some good comments in that session. We discussed delivery, like behavioral health integration. We did talk about rural again. We talked about how the integration between the prescribing and the providers could be improved. And we discussed that the primary care focus could be enhanced. We revisited the health equity as sort of the frame from which we are going to be trying to make system changes and program changes. And then we talked some about the other things going on in Oregon. The cost compact, of course, our 3.4% growth, the sustainable cost growth target program, and then just the changes that CCO 2.0 and the things that are happening with value-based purchasing at the Oregon Health Authority level. Next slide, please. This one's just kind of a reminder. What we were trying to do in the Lodestar 1.0 design was just take care of it. Just have the setup of the plan inherently make the 3.4%, fold in the 200% of Medicare, and increase the spending or ensure the spending on primary care is 12%. So it was kind of a constraint design system where instead of hoping for the best, we would build it into the program. Next slide, please. I'm not sure I want to go through this entire slide. This is just more what we saw on the RFI results. I've kind of summarized it already. So I think I'd like to leave that as a background piece if people want to go back and revisit it, but I'd like to talk about the next one more. So that's slide 7. Here's where we came to after speaking with you, reading the RFI, having a couple internal meetings. We kind of think that the Lodestar 1.0 pillars could maybe use reframing. The Lodestar 1.0 was essentially a health plan. It aimed at a vision. It involved direct contracts with prescribed value-based purchasing arrangements. And to that extent, it was innovative, prescriptive, specific. We are now thinking that Lodestar 2.0 might be more of a framework with a similar vision or, slightly enhanced vision that could be applied to existing health plans, future health plans, RFPs, not RFPs, that kind of thing. So it would be moved from more prescriptive to less prescriptive. It would retain the aspirations. It would not require an RFP to get it off the ground, but it still might benefit from an RFP. Looking at this slide, the advocacy-based member experience, alive and well, maintain and expand, consider health equity, and nothing there changing. You'll see the strike through on rationalized Medicare linked payments. Although we still think that's an interesting, valuable idea, we're suggesting that the Lodestar concept become a little broader. We remove that Medicare linked payment as an absolute, allow varying models, kind of like the value-based purchasing stuff we're already thinking about, monitoring and trying to improve upon, and then retain the option that if there is in the future, the time is right for a directly contracted Lodestar 1.0 value-based purchasing design to operate as a comparison or a contrast to the other health plan options. It's still there waiting to be born. The third pillar was quality-centric provider reimbursement. Again, that is a theme of healthcare purchasing this decade, and our suggestion is maintain and expand that pillar. Then the last one, guaranteed to meet global budget. We're suggesting that that option exists if we were to put out an RFP for the Lodestar health plan, but on this broader perspective of a Lodestar 2.0 framework, that we would follow more traditional approaches, where we would work with, follow, support the Healthcare Cost Growth Target Committee, focus on measurement, continue to use and improve on the performance guarantees that we've been talking about for PEBB and OEBB. And so we would not lose that Lodestar health plan, but sort of have an overarching Lodestar 2.0 evaluation framework, maybe. The next slide, please. Here, I'm going to hand it to Cindy, who's got sort of the crafted thought process of refining the design of the Lodestar purchasing framework.
Thank you so much, James. Can everybody hear me? Okay, good. So when we got feedback on the Lodestar RFI responses and reviewed that with this group, we received really important feedback, and it helped solidify the things that we knew we needed to definitely keep as we thought about the evolution of the Lodestar model into what we're proposing to call Lodestar 2.0. Some of the key things that you'll see is, and I think we heard this even with the Centers of Excellence conversation, that health equity really has to be the cornerstone of everything that is considered innovative and driving true health equity within the model. So you'll see that it's an umbrella of health equity, but we've kept the advocacy-based member experience component as that remained valuable, and we do have a mechanism to implement an expanded or adjusted version of the member advocacy experience. And using that member advocacy model or framework to promote the identification and using data-driven information to identify subpopulations and those that are experience health inequities. And using that to target the member experience or member outreach to members that might be experiencing those conditions. There's potential to look at carrier requirements to enhance management of social determinants of health and behavioral health issues, which we know overarchingly drive some of the health equity inequities that we see within members in vulnerable populations. And there's also still opportunity to direct members to providers with the highest quality outcomes based on what we've learned from the RFI. Another core component of the Lodestar 2.0 is increased quality-centric value-based payments. As we start to shift away from some of the payment models that were inherent in Lodestar, the original Lodestar, there'd be an emphasis on really weaving in the value-based payment compact that's widely been adopted in Oregon. Maybe review the plans VBP models with potential to increase the percent of provider payments that are tied directly to quality. And then the use of data analytics to identify high quality providers to not only direct members to those providers, but to reward those providers in a value-based model. The other element that we heard very strongly was the emphasis of primary care and behavioral health care in the evolution of the model. So we thought through exploring some value-based purchasing models that reward advanced and high quality primary care and integrated behavioral health care models. We did a brief environmental scan of primary care initiatives, particularly some of those that are already happening within Oregon, but also Washington State. There's several Medicare models, and we looked at the CPC model to determine some best practices potentially to include in Lodestar 2.0. And to use data to assist primary care providers in particular in addressing gaps in care, areas of waste, and perhaps influencing the integration of behavioral health care within some of those practices. Next slide. So one of the things we heard really loud and clear on the last meeting was that primary care truly is a cornerstone to high quality health care. And they're also the cornerstone of addressing health disparities, which is a key goal of the IWG and the OHA. So it's also reflected in a lot of initiatives that are already happening within Oregon. And we wanted to make sure that as we thought through Lodestar 2.0, that we were aligned and complementary with some of these initiatives. So we've begun a deeper analysis of what's happening here. So we won't go into a ton of detail here, just suffice to say we're starting to really look at the OHA's Primary Care Payment Reform Collaborative, which incidentally has the exact same goals. Our goals with Lodestar are highly aligned with the work that they are doing. And Oregon's patient-centered primary care home program, which again, we feel like we're aligned, but we want to evaluate the extent of OEB and PEBB's participation in the primary care home, and perhaps survey MOTA and province for ways to incentivize improvements in primary care. Next slide. We also briefly wanted to highlight Washington's model. More as an example of initiatives that are happening across the country to address the issues of primary care shortages and primary care reimbursement. We're not alone in thinking through these issues and coming up with models that seek to address primary care shortages and primary care reimbursement. So there is information out there that we can learn from, and Washington is just one of those examples. So leave that for your perusal following this meeting. Next slide. So what is the proposed path forward that we want you to, we're going to review and would love your feedback on? We had discussed at the last meeting that potentially conducting a gap analysis to determine current state and identify what changes, if any, might need to be made to achieve at least some of the innovation goals that we had in Lodestar, and start where we are today and see what it would take to move forward in the current model focus. So we plan to refocus Lodestar in these priority areas. So member experience stays. So we would evaluate and define gaps in advocacy-based member experience. How far away are we from best-in-class advocacy practices? Are there gaps between what is happening today and what we would consider best practice that are easily implemented? And implement those if those are reasonable to be implemented in the time frame, and create action plans to address areas that might require more innovation. In the area of health equity, really identifying how health equity is addressed today. We know that integrating race, ethnicity, and census information and demographic information is usually critical to identify who has health disparities within the membership. How far away are we from that today? And mining data to identify those subpopulations that have health inequity and what is driving that inequity. Perhaps surveying plans and providers on potential areas of inequitable care. Maybe there are ways that we can improve that. And then again, creating some action plans that identify the identified issues from that analysis. In terms of primary care and behavioral health care, supporting multi-payer primary care transformation. That could be linking and being complementary to some of the initiatives that are happening in Oregon and maybe incorporating best practices that we've seen nationally. We could also survey the plans for current VBP models that they might be utilizing that are working to drive advanced and innovative primary care and behavioral health care. Many states have done this, creating and publicizing and adopting a paradigm of transformation model. I think there's quite a few of those elements that we could adopt and incorporate into the Lodestar 2.0. And then think through does it make sense to incorporate that model into the current carrier market? Next slide. So to that end, these are the proposed focus areas for the gap analysis work. The first focus area would obviously be in health equity, that being a key primary core focus for OHA and this group. The gap analysis would include the objectives that you see here, but the desired state would be that at least for current state, that carriers are able to identify and meaningfully address health disparities. How far away are we from achieving that desired state? For behavioral health, the desired state is members will have improved access to quality behavioral health services. So we would conduct a gap analysis to identify current state and how far away we are from achieving that desired state, that goal. In the area of value-based purchasing, there is work that APAC is doing in order to analyze some of the VBP cost analyses. This gap analysis, we would really be looking at the carrier's ability to report validated VBP percentages and dig into the quality measures and performance improvements that have been identified and achieved through those VBP models. And then finally, focus number 4 would be to promote quality primary care and quality behavioral health care to the end of expanding access to primary care and behavioral health and rewarding quality providers who work within those specialties. And I'm going to pause because that was probably a lot for questions.
That's good. Thank you. Questions?
Yeah, this is Tom. On slide 11, you didn't include what on slide 12, the focus on value-based purchasing. I am 100% behind what's outlined on slide 11, those 3 different topic areas. The 4th one is what you then include on page 12, which is the focus on value-based care. My background is primary care. I understand it pretty well. I agree with the issues around the transformation that people have talked about in regards to the Oregon payment reform activities and the patient-centered primary care home activities. All of that is good. It's essential but not adequate. The other parts of the delivery system that we've talked about around centers of excellence and coordination of high-cost events like how we take care of cancer and other complex care, that also needs to be included for us to be successful in terms of getting to the triple aim and the cost controls. So that's the only feedback around here. What The only other thing that I have not seen discussed yet is maybe it's the hard part of care, and that's, do we ever get to a point where we ration? And the Oregon Health Plan initially, when it came about, was a system that focused on rationing by having the list. And I haven't heard any conversation around that yet. And I don't want to derange our conversation today, but at some point, I would love, and I can do it offline with Margaret, I would love to hear whether or not the IWG ever has talked about that. When I talk about rationing, I'm talking about, the cost per quality adjusted life year, and whether or not you're going to set some amount that at which, when you go above, you don't authorize.
Tom, it's James. I have some experience with the prioritized list and pricing it, and wondering how much the stuff below the line costs and what happens if the line gets changed. And I think it is a logical yet unpleasant topic. And some of the stuff below the list did look like low value care. There's no doubt about it. But the idea of drawing that line has been challenging, and it does still exist, but it's really it's not talked about much. It's not focused on much. There's a little suspicion that the plans go below the line and just don't charge.
And Tom, this is Margaret, just to chime in related to your specific question. The innovation work group really hasn't explored the prioritized list or analysis in sort of that framework to date. It's not a topic that the work group has covered, but would certainly be glad to talk to you more about your ideas on that.
I would propose that in about 3 years, the IWG take it on. that will be the time that I'll be transitioning off OEB. So
that makes total sense.
Makes sense to me too.
I think that's Jeff's timing too.
Yes.
We actually do have the HERC within our division at HPA, so I'm sure they would be happy to engage with us.
Well, the way to get to it probably is building it into the decision support part. The patients don't want to go through stuff that doesn't have value either. So there is a way for us to get at it, and I know it's being addressed. But there are a lot of other societies that have actively dealt with financial constraint, and you deal with financial constraint oftentimes by things like hip replacements in Canada. The queue is 6 months or 10 months or some incredible amount. But we need to. I was mainly interested in seeing whether or not that aspect of limited resource and rationing has been much of the conversation, and it probably is best for us to work with plans around low value care being discussed with the patient/member. Again, I apologize for derailing this one, but again, I think that you really have, on page 12, have really captured the where we need to be looking.
So you will be presenting all of this in September?
Well, we weren't sure what you would say, Jeff. And we thought that it might be that one or two of these options on slide 12 really won the day. Or it might be, go ahead and try to help look at the gaps on all four. We thought there were sort of two things we would do. One is, keep that little design vision thing on the Lodestar alive, put the tweaks in place, which is not a big job. And then the gap analysis. Now, summer's a nice time not to work too hard. So if you want to wait till after the 2 months off, we could talk about this again. if you'd like us to try and set up a small project plan to make more specific the things on slide 12 and spend a little time with our current plans, it might be that that would just keep, you know, the motion moving.
So I have a question. So for my part, I like the idea of a gap analysis, and calling out some of the details here looks good to me. I was curious about focus 1. I think it makes a lot of sense to start with data, being able to identify disparities and address them. There's always this little part of me that feels uneasy in regarding health equity in the medical system when we don't talk about culture, like the culture of the organization, including like the diversity in various ways of measuring that of the workforce itself, the doctors and such. So I wasn't sure if that was included in like this reporting and what have you. So I'm just throwing that out there. Sometimes when we talk about data and measuring and so on, which is absolutely necessary, it almost puts like the reason for the disparity on the member. You know, it's like there's a problem with the population rather than the culture of the organization. So I was just throwing that out there for food for thought and see if you had any initial reaction, but we don't need to solve that right at this moment. It's just throwing it out there. That's what struck me, but otherwise I'm on board.
Yeah, I think that would be an important part of our refining. You know, this health equity focus is not starting at a refined and elegant level. This is more sitting down and figuring, well, what does it mean? And what about the diversity of the provider side? And Emory sent me an article recently about provider care teams that are diverse or that are Emory, help me with it. It implied that Emory, are you on the line? Okay, I'll save it for later because I can't do it justice now, but it is looking upstream, not just at data around claims or members.
Yeah, okay, gotcha. Thank you.
So James, would you be able to bite one of these focuses and complete that by September? And if so, which one?
I think some of them are easier than others. Cindy, feel free to jump in here. I think we were prepared if you said yes, try to do this, that we could do them.
Okay.
We might want to get back to you on that, but I would suggest maybe health equity plus 1 or 2 as a way to move forward. You know, the value-based purchasing is tangential or similar to the stuff that Margaret already presented about the value-based purchasing work plan.
Yeah.
So we could let that be subsumed in that, or like, you know, that could be something that is not exactly part of the summer efforts. I guess if I were going to pick 3, I'd pick 1, 2, and 4. And I would say that there are other initiatives underway to try and improve value-based purchasing, both the qualitative and the quantitative. And then we could more monitor and track, participate, support, as opposed to start something that might be almost unappreciated or redundant or already underway.
I'm curious on focus 2. It wasn't that long ago that one of the carriers that our boards have worked with really had a shortfall of behavioral health professionals. I'm curious what our sense is of how well staffed our state is today, and especially with the pandemic influence on the need for behavioral health. So the adequacy part is something I'm really curious about, but may not be in the number one slot.
You're right, though, Jeff. There's when you think of network adequacy, there are available practitioners that we're just not contracting with for whatever reason, or do we truly have a shortage, particularly in certain behavioral health areas? Substance abuse, treatment springs to mind. That's typically a shortage in most states. So we would be looking at, is there an adequacy issue? And if there is, what is the driver? Because it can vary.
Yeah. I'm familiar with a few practitioners who are saying they're turning away patients. And it seems like our society is in great need right now.
Jeff, this is Michael. Just a couple comments, if I could, Cindy. One is about 50% of behavioral health providers nationally are not part of any network due to low reimbursement. Some parts of the country, like the Bay Area, at 75% are not in any network. So one of the issues is reimbursement. The other piece is when you talk about behavioral health providers, it depends. So psychiatrists, particularly child and adolescent psychiatrists, are are wanting in a lot of parts of the country. I would guess, actually, I just quickly read something around lack of psychiatrists in the state of Oregon. And also, I'm not sure if you saw, but Oregon State Hospital, due to lack of psychiatric nurses, asked for the National Guard to come and help staff because they were so short-staffed with psychiatric nurses. So there's clearly a need, and one of the advantages of optimizing telehealth is that can help potentially address some of that need.
Yeah. Well, it seems like there's a little bit of biting off your nose to spite your face here. If we're really ratcheting down reimbursement in this area, what are we doing in other areas of our healthcare? Meaning, if we're ignoring it, then we have an escalation of the condition.
Right.
Yeah, what are the unintended consequences?
Exactly. And I think I mentioned this before in a meeting with you, Sean, but I do have a major client that increased their outpatient behavioral health network. We did see a decrease in admissions and costs for inpatient hospitalization and residential treatment facility because you get upstream treatment. So although the outpatient costs went up, which I think is a good thing, although that makes my actuarial colleagues a little nervous, the inpatient and residential treatment costs went down more than the outpatient costs went up. So it kind of depends on where your focus when you talk about behavioral health costs.
And this certainly spills over into health equity.
Absolutely. Yep.
Yeah, it's a key driver for inequities, for sure.
Yep.
So I'm sorry, James, which ones did you say to concentrate on?
I was going to do 1, 2, and 4, and leave the value-based purchasing as, sort of a separate track for now that could be considered together. There is a fair amount of mainstream effort on value-based purchasing, not just the percents, but trying to get under the hood and see what's really happening. And I think, we could have more of a less work and more of a statement of belief.
So how does the group feel about that approach? I certainly would like to see that.
I'd support that.
I agree.
It's another voice.
Me too.
Okay, thank you. So charged. We'll look forward to September.
Okay.
With great
thanks.
anticipation.
We'll work with Ali and Margaret to make the details more detailed.
Excellent. I'm excited. Truly. All right, well, we're not too far behind here. So moving on to performance guarantees.
Yeah, thank you. And I just want to acknowledge right now, because this meeting was scheduled for 90 minutes today, we actually did not build a break into the agenda. So I apologize for that if anyone's feeling antsy. I'll run through these slides pretty quickly on the performance guarantees. This is essentially a status update just to let the innovation work group know where things stand in terms of work in progress. I'm then happy to take any questions as well. But to kick things off, just in summary, in terms of status, staff and Mercer have requested feedback and received that from the carriers on all areas of the performance guarantee requirements. We have refined aspects of the PG proposals based on the feedback we've received and had back and forth with carriers. That back and forth is still going on in certain areas. All of the carriers have agreed to 15% of administrative fees at risk for next contract year, which is the contract year that starts October 1 for OEB and January 1 for PEB. That 15% is spread across 3 categories of reporting, 5% each across administrative and operational measures, clinical quality measures, and financial trend. We are near final on the measures and scoring framework for the administrative, operational, clinical quality, and account management. Work continues for financial trend and transparency and clinical management. And just to note, overall, we're on track in terms of timing for having all PGs finalized well in advance of contract year start. Next slide, please. And again, just to summarize, the 6 domains are just shown here, different representation. The first 3 with fees at risk, the admin, operational, clinical quality, and financial trend. And then the bottom 3, account management, clinical management, and transparency, those being no fees at risk report only for the upcoming contract year. Next slide. On the administrative and operational, you can see we have ended up here after discussions with carriers with 9 measures in this category. We've had conversations around the specific measures, gotten feedback on those and around the targets. This is the current iteration of where this stands, which we have sent out and shared with carriers. In terms of the scoring, the approach we're taking is that each measure will be worth 1 point. So the carriers will receive 1 point for each measure where they meet the target. And we've basically broken the scoring down into thirds. So 7 points and higher, carrier retains 100% of fees at risk. 4 to 6 points, there's a 50-50 split between PEB, OEB, and carrier. And then 3 points or lower, and the 100% of the fees at risk are returned to PEB, OEB. So that is the general framework we're working on for scoring in that area.
Margaret, is there any difference between types of delivery systems? So closed panel versus open versus?
Yeah, there definitely are. So some of these, we tried our best to identify measures that were pretty industry standard. There definitely are differences related to how different systems may track things like inquiries from members, questions that come in from members, and that's one example, whether those come in by phone or email or both or through different modes. Where we've ended up on this proposal, and what this presentation doesn't include is every version of the metrics prior to this, but where we've ended or where we've landed here sort of reflects us receiving a lot of the comments and feedback from carriers and really trying to modify or refine the proposed measures so that we're taking into account or acknowledging those differences. And it is a balancing act because we want to acknowledge where differences exist while at the same time have aligned generally comparable measures across contracts.
So one area that I'm a little concerned about is 3 and 4 together. As we are migrating towards advocacy-based, we don't have a measure for hold time, and the objective of advocacy-based response is that they not be put on hold. That's related to abandonment rates, but not exactly. So I don't know whether there's an appropriate differentiation between the model there or not. Just to, so have you resolved any questions with the carriers, or is this final, close to final?
This is close to final. We have resolved the majority of questions. Now I do want to note that resolving questions from carriers does not mean that every target is set at the level that each carrier suggested we set the target.
Sure.
We had to take in all of the comments we received from individual carriers and consider them in their totality. And so there were certainly some instances where carriers expressed displeasure with a given target. And I think we have worked to the best of our capability to consider those across the carriers that are all involved in, entering into contracts with us, and make the make refinements where we can. Carriers we have sent this out to carriers for one final round of review. And of course, contracts are not signed yet. So, folks ask, are things final? And I mean, there's a part of me that says, well, things are final when the contracts are signed. But we are very, very near final on these particular measures. Are there other questions related to this? And I can certainly understand there are. I will be candid in saying that for certain carriers, there are probably certain measures that may cause a little heartburn. But our hope was that we were providing a kind of a comprehensive collection of reasonable measures with a reasonable reporting burden that we could look at across contracts.
Okay, thank you.
Are there any other questions? Okay, so next slide, please. The next category is our clinical quality measures. And this is a little bit of a longer list, so not everything fits on one slide. We did land with 15 measures here. And if you can go to the next slide, Rose, talk a little bit about where things stand with these. Our current proposal is that for all measures, targets are set at the 66.67th, 75th, and 90th HEDIS national percentiles for commercial plans. And so scoring would be based on where carrier performance ends up being relative to those targets. So carriers would receive 1 point for achieving the 66.67th percentile, 2 points for achieving the 75th percentile, and 3 points for achieving the 90th percentile. In terms of scoring, we are proposing or looking at, and we're still refining the thresholds and approach for scoring, but we're looking at a framework that is similar to what you just saw for the administrative and operational plans, where carriers would have a threshold that they needed to reach, a threshold of total points to retain 100% of fees at risk. Beneath that, there would be a corridor, and within that corridor, it would be a 50-50 split on the fees at risk. And then there would be a floor where essentially if they did not achieve the floor point total, then 100% of fees at risk would revert to PEBB and OEBB. So, and that is just sort of in an effort to, again, there were, because there's been pretty significant disruption in our data for the past, for 20 and 21 performance years due to the pandemic. We considered a lot of different options around what we could look at in terms of baseline data if we wanted to look at improvement over time for carriers. There are considerations and complications with that approach, and where we ultimately landed was that if we look at the carriers' 2022 measurement year data and simply compare their scores to what the national percentiles are, you're getting an apples to apples comparison. You're not looking back at prior years where you could run into a situation where perhaps, specifications may have changed, or measures aren't trendable due to HEDIS technical specs. And also situations where you're trying to look back at a baseline year that was during a pandemic where data is just not considered to be what we would typically expect. So this approach we feel is really sort of a straightforward way to look at how the carrier did in a measurement year relative to the national percentiles for that measurement year.
So are there differences? Are there regional percentiles as opposed to just the national?
For HEDIS and in terms of what they publish available, and I don't know if Michael's on the line from Mercer, if Quality Compass incorporates regional percentiles.
I don't think so, Margaret. I think it's just national. They do break it down by model type. I also just wanted to make a quick comment. Jeff, you asked a question about closed system versus like a PPO, and both the operational administrative measures and the clinical management, it doesn't matter whether it's open or closed. Those are applicable. They're NCQA standards or incorporated into NCQA standards, regardless of whether it's an HMO or PPO.
So what about immunizations? That's an area where Oregon tends to buck the national norms.
Yep.
Inside a closed system, you really have the potential for a more united front in terms of pushing for immunizations, where in an open system, you might not.
And that's where the benchmarks are different, right, Margaret?
Yeah. So if we talk just a little bit more, I'll go over the next couple bullet points and we can talk more about that question.
Okay, thank you.
Yeah, absolutely. So for HMO plans, we will be using the HEDIS National Commercial HMO percentiles. And then for CCM and PPO plans, we will be using the HEDIS National Commercial PPO percentiles. However, to note that for CCM plans, they will have a higher total score required regarding the fees at risk retention. To recognize that we expect that, relative to a PPO, a CCM should be demonstrating some quality differential.
Absolutely.
So in answer to your question, Jeff, I mean, typically what you see with HEDIS is the HMO percentiles, I guess, reflective of more of sort of a closed or managed system. You could say they typically run a little higher than what you would see for the PPO percentiles on a given measure. So we are trying to make allowances for that by comparing each plan to national percentiles that, as close as possible, align with the model.
Okay.
And again, go ahead.
Margaret, they don't, the HMO percentages don't typically, they consistently are higher than the PPO models. It shows our focus on integrated systems of care in OEBB has been, let it be, the Kaiser Permanente system or what MODA is doing. We've been moving in that direction for years because we know that we get a higher quality. So it has been consistent, and as laid out here, our expectation is that the CCM 2.0 with the PCP 360 will deliver a higher quality of care. That's we're waiting, and the way that you've outlined it to compare apples to apples with the not trying to compare it to previous years and impact of pandemic is exactly the right way to do it. So I think that what you've done is this, what you've outlined here I think is very good.
Great, thank you, Tom. And yeah, I appreciate your comment, because my statement of typically was probably conservative in terms of that the HMO percentiles are consistently higher than PPO. Yeah, absolutely. Are there other questions related to the scoring. One thing I also want to note just on the scoring is that we did try to build in, some incentive where we could to achieve those higher levels of performance. I mean, building in 3 points for measures where carriers achieve the 90th percentile. That is something new that we haven't historically done in our clinical quality measures and contract. But I think it was a way we identified that we could provide some recognition for carriers who are achieving those high levels of performance on certain measures.
And the only thing that I would suggest is at some point to look at that, that 90th percentile, and actually what you're doing here is you're allowing plans to gain back what was already negotiated in their administrative fees. It would be interesting to see if there's an incentive that can be put, essentially a positive that plans can look at if they reach, a stretch goal.
Yeah, agreed. That's certainly when, in terms of the comments we've had and some of the feedback we've had from carriers, that's definitely something that's been highlighted, that it would be nice to consider if at some point there is a true incentive related to the approach to fees at risk in terms of how the dollars are considered.
Yeah.
Do you have sorry, Tom, go ahead.
We could have actually done that this year, I think, with OEBB, in that when we came up with our rates, we came significantly below the aggregate 3.4, and we could have potentially even taken a 0.1% and hold it in reserve for a quality bonus as such. But we didn't have time. We didn't have time to think about it. But that's something that we may want to be thinking about in the future.
So, did you by any chance do any analysis where you took these 15 clinical quality measures and looked at where they are today and what the gap is and what how much of a stretch it is to get there?
Well, so in terms of where they are today, I mean, we have, for some of the measures, we can look back to what's essentially calendar year 2019.
Yep.
And we know how carriers have been performing on some of them. Some of them are new. So we don't necessarily have historical data on those if they haven't been part of our set before. So we can look back at 2019 and see how performance was. We don't know 2020 performance yet, because that will be submitted on a report-only basis, no fees at risk, to us later this summer. And same for 2021. I mean, we'll get 2021 data next summer. So, in terms of right now, I mean, I think that, there has been general commentary out there that, there are concerns about, how far certain measures like screening measures and such may have been impacted by the pandemic. We don't know yet that information for our particular carriers. But again, I think, historically we have set our target, or in the past, the way our quality measures have been set up is that carriers have had to receive they have had to hit the 75th percentile in order to basically get credit for the measure. So the 75th percentile has kind of always sort of been our target of where we've wanted carriers to hit. That's not to say they've hit the 75th percentile on every single measure, but I can tell you that to date, our carriers have not had to return fees at risk on quality measures. So they have been meeting enough targets to date at that 75th percentile position to stay whole on the fees at risk. So we sort of looked at that 75th percentile as a target, as a generally reasonable target, and then acknowledging that we still want to recognize where carriers maybe are not hitting the 75th percentile, but are still, demonstrating some movement in quality. We've added the lower 66.67 percentile at that initial 1-point position to still, provide some recognition even for those cases where they're not achieving the 75th.
Yeah, thank you. I was going to ask you next. So do you have enough stretch in these? Come at it from the other direction. So
yeah, well, I think that's a good question. I mean, the 90th being the stretch. I mean, we have occasions in the past where for measures where carriers have been meeting the 90th on some of them. I think again, there's a lot of concern about how everything's going to look sort of post-COVID, and I certainly get that because it has been a difficult year on that data front, but I think recognizing that these go into effect, it's measurement year 2022, and we are trying to stagger it and acknowledge the the 3 different percentile rankings in terms of where carriers can get some credit on their performance, and as previously noted, not comparing to historical data, but really just looking to how they compare to the national percentiles.
thank you.
Yeah.
Any other
okay.
questions?
All right, we'll go on to the next slide and go ahead.
Can I ask a really quick question?
Yeah, of course.
The percentiles, they're recalculated every year, are they?
Yeah, so every year NCQA, based on all carriers nationally that report data, they crunch the numbers and release the percentiles for that year based on
the percentiles then nationally would take into account COVID.
Oh yeah. So let's say that immunization rates have dropped across the board, like have dropped nationwide, the percentiles will be lower. So that's part of the rationale for comparing the measurement year's performance to the measurement year's percentiles. As some of that definitely will be taken into account. Right. Okay, next slide, please, Rose. Thanks. On the financial trend guarantee, we talked about this one in some detail last month. The proposed trend rate guarantee, again, it requires a total cost of care per member increase at 3.4% or less. Under the proposal we've developed, if a plan's cost increases 3.4% or less, there's no penalty. They keep all the fees at risk. If the increase is between 3.4% and 4% within that corridor, they have a penalty of half, essentially, of the total fees at risk. So 2.5% of the fees at risk of the administrative fees would apply. And if the cost increase is over 4%, the full 5% of fees of administrative fees at risk would apply. And so where we are currently is that carriers have provided comments on the methodology we proposed. The comments they've shared are under review internally, and we're preparing responses to all the comments and questions they've shared, and considering refinements to the guarantee proposal based on those comments. And that is in process, and I expect will continue for the next several weeks as we finalize this particular guarantee as well. Next slide. On the account management, we are pretty much set here. I think this was presented in a prior month. It just notes we have a collection of 6 measures that we're going to assess each of our carriers on in terms of their account management, and the rating methodology is listed. We anticipate that what we'll do is we'll have this rating. We will ask, it'll be completed annually, and we will ask the board to designate a couple of board members, perhaps the chair and vice chair of the board, or whomever they may opt to designate, as well as a collection of PEBB and OEBB staff will complete this rating on an annual basis. Next slide, please. Clinical management. For the clinical management section, there are 4 measures you can see listed here. And in terms of where we are here, we are still in the process of receiving and working through some additional carrier comments, which are under review prior to us finalizing And Jeff, this goes back to a little bit when you referenced different models of care. In some of the conversations we've had with carriers, it seems, certain of these measures may not lend themselves as well to different models of care, depending on how a particular health plan may structure its internal care management activities. So I would say that generally speaking, the comments we've received are reasonable ones, and we're just working through them on a path to finalization.
Great.
Right. And I think, Rose, I think this is the last slide. Transparency reporting being the last category. Work is in progress to define technical specifications for the reporting areas. And as described before, there are 4 particular reporting areas in the transparency realm. Value-based payments, percent of Medicare by service category, unit cost increase, and payment variability. And all of those reporting categories, specification development is underway. So are there any questions?
Good, thank you.
That's all I have, I think.
I don't see any hands. Okay. Well, we need to make the call for public comment. This is where Rose gets to speak.
There is no public comment unless there's somebody on the phone who wants to make some.
Okay. Anything else for the good of the order before we break for the summer? Okay, thank you all very much. Look forward to seeing you again in September.